Everyone, welcome, welcome. I love the little music and the dancing. I feel like it gets me all hyped up. I hope you guys are awake and feeling good on this Tuesday morning. For those of you who don't know me, my name is Hiva Kolodrobitz. I'm a family nurse practitioner with Archer Review. I'm a content creator as well as an instructor. So I do a lot of mentoring and teaching with nurses and nurse practitioner students. So thank you for joining me today. We're going to be together for the next 2 hours. And feel free to pop in and out, but I'm going to hopefully keep your engagement and get you guys to participate with me in today's webinar. It's something new that I'm trying to see how it goes and how you guys like it, so I really welcome your feedback. What I did was I put together a comprehensive pharmacology review. So I took all the high-yielding medications that we frequently prescribe as nurse practitioners and broke it down by body system and wove in some test prep questions as well as create some case studies for you guys to really help solidify some of these concepts. So hopefully you're not only remembering it for test day, but it also sticks in your brain when you're in your clinical practice. So it's a new webinar. We're going to have some fun with it. Hopefully you'll join me in having some fun. One of those tools that I like to use to get you guys to engage with me and really help that information kind of stick in your brain is using Slido. So some of you may have already tried Slido in the past. Slido might be new to others. It's really a fun way to ask you guys questions and get you to answer in a poll setting, and we'll try it this morning. And so it's anonymous. You can't see who answers what answers, but you can see your peers' answers. And so it's kind of a fun way to see and take a guess without it, causing any embarrassment for everyone, and really try your best to get the answer that you think is right, and then learn about what your peers are thinking, and then we'll talk about the right answer together. So for those of you who have used Slido in the past, you can scan this QR code with your phone and it'll take you right there. If you're watching on your phone and you don't want to toggle back and forth between the screens, the phones usually do a pretty good job of having the presentation over on the right-hand side of the bar while Slido is going, but maybe you want to pull it up on your computer or you just want to do everything on the computer today, you can go to slido.com and you put in the hashtag farm for NPs. And so it'll take you to our first poll this morning that's already started. And so these are just kind of fun ways to get us warmed up on Slido to make sure that we're all comfortable using it. So I have just a couple of fun Slidos that I'm going to try with you guys before we really get into the content. So first one here is, where are you joining me from? And so typically I get a lot of people both nationally and internationally, which is really fun to see. So already we're seeing some responses. We see some people from Texas. That's where I currently am. I see some people from Florida, DC, New Mexico, Michigan. So kind of all over the place. This is awesome. And so I'm originally from the Northeast myself. That's where I did the majority of my training. I've practiced in Massachusetts, California, and now in Texas. So it's nice to see everyone from all the different states all across the US. We're not seeing any international people yet this morning, but sometimes it takes a little while to get Slido to work. Again, here's that QR code for you. And then you can also go to slido.com and hashtag farm for NPs. And I see a couple more responses from West Virginia, Connecticut. Welcome, everyone. Charlottesville. This is great. So really, we're getting all over. This is really nice. All right, let's go to our next fun Slido. And who's in the audience today? So I'm trying different types of polls so you can also get used to how you can respond with the different types of polls. So who's in the audience? This is more of a select as opposed to that word cloud that you saw in the previous one. And so majority of our participants today are nurse practitioner students. We have some RNs in the audience and also some NPs. That's great. And so you can be anywhere in your clinical journey or in your nursing journey. Some are still students, some have recently graduated, some are just starting their first job. So a lot of exciting things for everyone. So it looks pretty even on between nurse practitioners and nurse practitioner students, and a couple of RNs maybe considering the NP role, or really using this webinar as a nice refresher for you too, because I'm going to go through all those high yielding medications. Awesome. Let's go to our next fun poll. So where are you in your NP training? Are you just getting started? Are you finishing up your school and getting ready to sit for your boards? Have you passed your boards exams and you're getting ready for clinical practice? Tell me where you are in your nursing career. Okay, seeing a lot of responses of finishing up and getting ready to sit for the boards. Yeah. Past your boards and getting ready for clinicals. It's an exciting time and just getting started. Awesome, you guys. And this is usually what we see for our webinars. We see a lot of people hear about us when they're getting ready for their boards exams. And as word of mouth spreads, you realize that, wait a minute, Archer has a lot for nursing, and I could be using Archer all the way through my training. So we're getting a lot more students kind of making that transition from RN to NP and using us as their mentoring and the support system as they're going through that training, because it can be a lot, right? Getting ready for your clinicals, finishing up your didactic, making sure you get the clinical experience you need, sitting for your boards, passing your boards. And then once you've passed, getting ready for clinical practice, how do you apply all that knowledge to real life case scenarios? And that's why I'm putting case studies into today's lecture. The best way to learn is to really see patients. If you don't have that experience, how can you get it? Through cases. And the cases that I've put together for you guys today have, I drew a lot from my own clinical experience to help you guys kind of solidify some of those concepts. And then we have a nice little rating tool here. How comfortable are you with prescribing? So on a scale of 1 to 10, let me know where you stand today. Are we feeling not so comfortable, very comfortable, kind of all over the map? Yeah, and that's okay. You guys are doing great with Slido. Yeah, so we see kind of right in the middle is the majority of the audience today, right? Maybe a couple people who are just getting started, not feeling very confident. Some people getting ready to really sit for their boards exams. They've had a couple of clinical rotations under their belt and they're getting ready to enter clinical practice. So right in the middle there. Beautiful. Awesome, awesome job. And then last, I like to throw in a really fun one. So this is what we call the free text poll. So you can kind of type in whatever you want. So tell me, what is your New Year's resolution for 2025? I don't usually make New Year's resolutions, but I did this year. And my resolution is to really slow down and have fun in life. I think that's a really hard one when you're go, 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 and you're driven and you've got a lot of big plans. But I really want to share that with you guys as you're really going through this rigorous training and entering a job where it takes a lot to really care for other people. I want you to make sure that you're also caring for yourself. So that's been my big thing. Sam, who's here for our chat support, she'll probably know that that was also my big thing in 2024. So I don't know if it's a New Year's resolution for 2025, but I'm definitely trying to slow down and make sure I'm taking care of myself so that I can take care of others. So that's going to be my big thing in 2025. And so let's see what you guys said. I see more mindfulness, kindred spirits there. I love that. And I see a lot of pass my boards, a lot of get certified, pass my boards, and not really a resolution, but want to pass my exam and start practice. I think that's a resolution. I think that's a pretty good goal for 2025. I guess it depends on your definition of resolution. All right, well, you guys are all pros at Slido now. We had some fun here. And now we're going to jump into the content, and we're going to be using Slido throughout. So keep it open however way you used it. and we'll go through it throughout today's presentation. So some quick tips and tricks before we really get into the different classes of medication. The first thing you want to be thinking about when you have a question, maybe on the board's exams, that's really directed at pharmacology, or you're thinking about prescribing a medication, safety is always first. So think safety. The majority of the time, the boards are going to try to make sure that you know what's happening in terms of the pharmacology of that class of medication. What are the contraindications? What are the side effects you need to educate your patient on? What do you need to be monitoring? And what are the absolute no-nos? So those contraindications are going to be really big with safety as well. So those are the things I'm going to be highlighting about the classes of medication today. But when you're thinking pharmacology, always think safety first and err on the side of caution. You really want to learn the pathophysiology of the drug classes. We're going to go into some pathophysiology today, but again, this is a high-level review because we really want to cover a lot of bases. So if you find that it's kind of over your head in some of the sections, you want to make a note and go back and study those sections and really do a deeper dive into the pathophysiology. Once you understand how that drug works, then you can really start to recognize, well, that makes sense for the side effects, and that makes sense for the contraindications, right? And that makes sense about how I'm going to prescribe it. How long does it take to take effect, right? So understanding that pathophysiology will really help you in the long term so that you're not just memorizing, you're understanding. And then when you're actually in clinical practice and you're seeing patients where it's not textbook, you can really draw from your knowledge, right? So this is the time to do those deeper dives. Certain populations that we always want to keep in mind, especially as they come up on boards questions or in your clinical practice, children, elderly, patients with liver failure, kidney failure, pregnancy, breastfeeding, those are all specialty populations where we really have to be extra careful and be thinking about those contraindications and those side effects. So keep that in mind because really drug metabolism, absorption, excretion really varies in those patient populations compared to that average patient, right? So especially if you're getting ready for your FNP boards and you're getting ready to see patients in family practice, which a lot of you said you were, you want to be keeping that in the back of your mind because these are going to be patients that you'll be serving. Okay, so those are just general tips and tricks as we go through today. So let's start with our first practice question, and we're going to go to poll 6. And so we'll read it together on the slide, and the poll is open. So if you're ready to answer, you can go ahead and answer in the poll. The nurse practitioner is choosing an initial therapy for hypertension and wants to use a diuretic. So they're telling you the class of medication, they want you to use a diuretic. After reviewing the evidence, which of the following would be selected as the best first-line diuretic to use in hypertension? What do you guys think? Is it A, B, C, or D? Is it going to be chlorothalidone, hydrochlorothiazide, Lasix, or spironolactone? What do you guys think? A, B, C, or D? And let's see what our peers are saying. Yeah, I'm going to give everyone a few more minutes. Yeah, and this, I have to be honest. So when I'm in clinical practice, I still will prescribe hydrochlorothiazide over chlorothalidone. Absolutely. But I see some people wrote chlorothalidone. So the right answer is actually A, chlorothalidone. And so chlorothalidone is the best first-line thiazide diuretic for hypertension. It's now superseded hydrochlorothiazide because it's a little bit more effective in reducing blood pressure than hydrochlorothiazide, and it's better at preventing morbidity and mortality in our patients with hypertension. However, in clinical practice, if you have a patient where you just need to take a little bit of that edge off with their hypertension, I certainly still prescribe hydrochlorothiazide over chlorothalidone. So this is really what the evidence shows, what the guidelines are telling you, but those are just guidelines, right? It's not fast or fixed. So you need to still be looking at each patient on a case-by-case scenario. Lasix, we're really not going to be prescribing Lasix as our first line because this is more for patients that we want to diurese them pretty quickly. And then same with spironolactone, that's a potassium sparing diuretic. It's not going to be our first line. And we'll get into the nitty gritty of all those diuretics. So again, those three classes of diuretics that we just talked about are our thiazide diuretics, our potassium sparing diuretics, and our loop diuretics. So with the thiazide diuretics, it's really going to help reduce that blood pressure by promoting the excretion of sodium in water. In those potassium sparing diuretics, it's going to block that absorption of sodium in the distal tubule. So all these diuretics work primarily in the kidneys, and it's going to allow for that urination, that excretion, while holding on to that potassium. So with that decreased potassium loss, what are we thinking about? And you guys can go ahead and put it in the chat for me. What are we going to be monitoring for with our patients who are on those potassium sparing diuretics if it's holding on to the potassium? Absolutely. That's right. So hyperkalemia, right? So we want to be looking for those elevated levels of potassium. Awesome. And then with our loop diuretics, like I said, these are reserved for more severe cases of hypertension. We use it in our patients with heart failure. It's really more for rapid diuresis, and it's going to really inhibit the absorption of sodium, potassium, and chloride ions in the kidneys in that loop of Henle. So it's really just getting rid of everything. And that's why we see such rapid decrease in the blood pressure and such a large volume of diuresis. So it really does lead to a large volume of urine production and decreasing that fluid retention in the body with those loop diuretics. So definitely not first line in our typical antihypertensive case. Other classes of medications, other classes of antihypertensive medications that we will be looking at, ACE inhibitors and ARBs. We'll talk about how they block the angiotensin, the RAAS system. I'm going to show you guys that, and then also calcium channel blockers and beta blockers. Remember, with those ACE inhibitors, it's really blocking the conversion of that angiotensin 1 to angiotensin 2. With ARBs, it's blocking the action of angiotensin 2. And so both those will really prevent that vasoconstriction, right? And with our calcium channel blockers, it's really going to block that calcium from entering the cells, both in the heart and just the blood vessels, and that'll help relax the blood vessels and also lead to vasodilation. But a lot of times we're going to be managing hypertension using various different classes of drugs and not just one class of medication. So it's important to know how to use them and what their pharmacology is so that we're not using an ACE with an ARB, right? Because it's going to be the same mechanism of action, pretty much. And just a little fact here, hypertension affects about 45% of US adults, so definitely something that you'll get really comfortable with prescribing in clinical practice. So with the pharmacology, I'm not going to go too in depth with this RAAS system, but remember, this is your renin, angiotensin, aldosterone system. These are really hormones in the body that help us regulate our blood pressure. So if you'll remember, renin, it gets released by the kidneys and it responds in a lot of different areas, but basically it helps lower that blood pressure. And when we block that, it's really blocking the initiation of that angiotensin system, right? And then with those ACE inhibitors, it's blocking that angiotensin 1, converting to angiotensin 2. ARBs are really blocking that angiotensin 2, so we don't want a patient on an ACE and an ARB together, but I think you guys already know that. I would be lying if I said I didn't see it in clinical practice that we have patients on both ACEs and ARBs, and you have to correct that. Oftentimes, if patients are seeing multiple providers and getting prescribed different things, patients won't know, right? It's our job as clinicians to educate our patients, so we want to really make sure that we're looking at their full medication list every time, and we're making sure we're cleaning up anything that's being duplicated like that. And then aldosterone, of course, it helps increase that sodium water absorption in the kidneys by raising the blood pressure in the blood volume. So if we're blocking the aldosterone system through the RAAS with those ACEs and ARBs, it works that way as well. Okay, so talking about those ACE inhibitors, so that's the angiotensin converting enzyme inhibitors. Usually they end with the pril, so you have enalapril, lisinopril, benazepril, so you see that end sound with the pril. Typically on the boards, if they give you a medication, they're going to give you the generic and the brand. So if you focus on the generic name and you're looking at those end sounds, it'll help you with remembering the class of medication, or at least knowing that, okay, this is an enalapril, lisinopril, this is an ACE inhibitor with those prils, right? With those suffix. So with our ACE inhibitors, remember again, we're blocking the conversion of angiotensin 1 to angiotensin 2, which really blocks that vasoconstriction, allows for some vasodilation. It also decreases the aldosterone production, so that's really what leads to that vasodilation. And we talked a little bit about this, but we really want to watch for those side effects. Pretty typical side effects, of course, orthostatic hypotension. We're trying to achieve lower blood pressure. Sometimes we'll get a little bit of hypotension, so we have to watch for that. Orthostatic is if they're changing positions and they're feeling lightheaded when they change positions too rapidly. And then we see the dry cough with ACE inhibitors a lot. The dry cough is not something that is harmful to patients, but it can be bothersome. And so some patients will want to switch classes of medication because they're not happy with the dry cough. So that's something we have to think about. Adverse effects that we want to have on our radar, there is an association with angioedema with both ACEs and ARBs. Less so with ARBs than with ACEs, but if you do have a patient that presents with angioedema and they're on an ACE, that's going to be one of the top things on your list of differentials as potential cause for the angioedema. Hyperkalemia, we talked about that already. The other big thing, really big contraindication during pregnancy with ACEs and ARBs. So you want to make sure that you're keeping mom safe. If you have a patient who is planning to get pregnant, you do not want to start them on an ACE or an ARB. You want to be looking at a different class of medication. And then you want to avoid the use of ACEs and ARBs with potassium-sparing diuretics, again, for that increased risk of hyperkalemia. All right, moving on to our ARBs. So these are the angiotensin receptor blockers. So this is what ends in that artin. So you're going to get losartan or valsartan, most commonly prescribed. And so again, we can use it in our patients with hypertension, heart failure, our diabetics to really help protect those kidneys. How does it work? It works by blocking the action of the angiotensin 2 receptor, so it really prevents that aldosterone production and leads to vasodilation. It also increases excretion of water and sodium, so it helps reduce both that preload and that afterload on the heart. There is still, if you look at the prescribing considerations, it's pretty much identical to ACEs just because of the way it works and the mechanism of action. But remember, it's not the association with the dry cough and angioedema is not as high with ARBs as it is with ACEs. But you still get the risk of hyperkalemia, and it's contraindicated in pregnancy, and you want to avoid using it with other potassium-sparing diuretics. So you want to really be grouping ACEs and ARBs in your mind together if you haven't already. Typically, if we have a patient who's doing well on an ACE, but they don't want to stay on it because of that dry cough, I will try an ARB, and most often it'll be fine. They won't have the dry cough. The dry cough will go away. Every now and again, I still have the persistent dry cough, and then I'll have to switch them to a different class of medication altogether. But you can still try the ARB if they're just not tolerating the ACE inhibitor just because of that dry cough. So that's a little clinical pearl for you guys. All right, let's talk about our calcium channel blocker. So how does this class of medication work? It works by blocking that calcium from entering the cells in the heart and the blood vessels. It then relaxes those blood vessels and leads to vasodilation. Remember, calcium is an electrolyte, right? And it causes the heart and the blood vessels to contract. So if we're blocking it from entering those cells, then it's really going to help vasodilate. That's how we're getting the vasodilation. There are two two classes, which we'll talk about today. Biggest, most common side effect with this class of medication that I see is that lower leg edema. So typically, if I have a patient who already has a little bit of lower leg edema, I'll probably try a different class of antihypertensive medication. I'll reserve calcium channel blockers for only if I need it in that patient. Sometimes I will also see patients come in with that lower leg edema new onset because of the new calcium channel blocker that I started them on, and they really don't like it. So we have to try a different class of medication. So that is really the most common side effect that I see with this class. Now, biggest caution with this class is the heart block, and that's because of the pharmacology or the mechanism of action, how this class of medication works. Remember, calcium is necessary for proper electrical signaling, particularly at that AV node. So if your calcium channel blocker is doing too good of a job, right? If its effect is significant enough, it can really cause some serious heart block. So you really want to be cautious in patients who may already have heart block, and you want to watch for that if you're starting a patient on a calcium channel blocker. So that is across the board for the class. So let's talk about those two different classes of medication. So you have the non-dihydropyridine calcium channel blockers. These are more selective in those heart muscles. So this is your verapamil and your diltiazem. Again, it's indicated for hypertension, but we also use it for angina and for those dysrhythmias, right? Because it's more selective in those heart muscles. So we're going to use it to help us out there. Again, it blocks that calcium in the heart and blood vessels, so allows for that vasodilation. It also slows the heart rate down, especially at that AV node, like we talked about, and decreases the force of the contraction. So really helps with perfusion with our angina patients and also with those dysrhythmias. Some prescribing considerations to be thinking about. So potential side effects, again, we're lowering that blood pressure. We want to be watching for the blood pressure being too low and patients becoming symptomatic. So dizziness, hypotension, facial flushing. Occasionally I'll see headaches too is a pretty common one. But again, across the board for the class, lower leg edema is going to be the most common. Some adverse effects, remember we talked about, we really want to watch for those heart blocks, AV blocks, and any signs of bradycardia, really slowing down that heart rate too much. Some interactions, so it does enhance the cardiac suppression of digoxin and beta blockers. So if you are giving it together, which you most likely are not, usually cardiology will be comfortable enough to give them together. You can just really help monitor this patient a little bit more closely when they also come to see you in primary care and you're co-managing them with cardiology. And biggest thing, again, with this class of medication, you do not want to be giving it in patients with already pre-existing AV blocks, or if their heart failure is due to reduced ejection fraction. That's going to be a big one. It already decreases that force of the contraction, so we don't want to be contributing to their underlying heart failure, right? So we want to be watching for that. Grapefruit juice, I won't go into the full details, but just remember grapefruit juice reduces the absorption of calcium channel blockers, so it can increase the risk of having some of these adverse drug reactions. So you really want to make sure you're counseling your patients on that if you're starting them on these medications. Okay, moving on. Now we have our dihydropyridine calcium channel blockers. These are a little bit more easier to remember because they do have a suffix with a dipene. So if you notice in the last one, you just have to know verapamil and diltiazem fall in this class. With this class of medication, they do have a suffix with a dipene. So you have nifedipine, amlodipine. Those are going to be the most common ones you'll be prescribing. This is more selective in those blood vessels. So remember, the other class of medication was more selective in the heart, so we used it with angina. We still can use this with our angina patients. Calcium channel blockers in general are going to be really helpful with perfusion in the heart, but typically we're going to use this more for our patients with hypertension. Works in the same way. It's the same class of medication, so it blocks the calcium channels in the heart and the blood vessels. That helps lead to vasodilation and increased coronary perfusion. It is more potent in reducing blood pressure than diltiazem and verapamil, so just be mindful of that. So you definitely want to start lower and go slower with amlodipine. That's typically my go-to. And it does cause the same side effects. So with that dizziness, flushing, hypotension, the lower leg edema. Now, with the reflex tachycardia, remember, what is reflex tachycardia? It's when the body tries to increase that heart rate to compensate for the drop in the heart rate and the drop in the blood pressure, right? So if it's too potent, if it's too effective, you might get reflex tachycardia. And that's why there's a higher risk of reflex tachycardia with this class of calcium channel blockers than the other class of the non-dihydropyridine class of calcium channel blockers, because it's a lot more potent. So be mindful of that, especially if you're combining it with some other classes like beta blockers. If you're combining it with some other classes, you may want to use a beta blocker to help rate control that patient to help prevent that reflex tachycardia. And we'll see cardiology doing that a lot as well. This is used preferably in those patients who really can't tolerate the non-dihydropyridine because of previous AV blocks or known AV blocks, or if they do have a low ejection fraction due to their heart failure. So this might be a good calcium channel blocker class medication to try. So it has the same interactions with grapefruit juice that we talked about previously. You really want to be educating your patients and then watching for it, because it can increase the risk of those adverse drug reactions. Moving on to one more class, and then we'll jump into a case study, I promise. So now we're going to talk about our beta blockers. These are our lulls, so the suffix ending in LOL or lull. You have selective and non-selective beta blockers like metoprolol and propranolol. Indications, you can use this in a myriad of things, this class of medication. You can use it with hypertension. It's not going to be our first line for hypertension. Typically, we're going to use it more in arrhythmias and trying to rate control patients, but it certainly does help with hypertension as well. It blocks the effects of the hormone epinephrine, also known as adrenaline, and that causes the heart rate or the beat to become slower and less forceful. And so that helps result in lowering that blood pressure. Now, remember, with this class of medication, with your selective and non-selective, we have some serious contraindications that we want to be thinking about. Selective works on those beta-1 receptors. Non-selective works both on beta-1 and beta-2. Now, who can tell me where our beta-2 receptors are really important? What patient population are we worried about? And it's on the slide, but what patient population are we worried about with those beta-2 receptors? You can go ahead and put in the chat for me. Yes, absolutely. Those beta-2 receptors are proteins found in those airways of the smooth muscle cells, right? And that's what really helps relax those muscles and open those airways. So if we're using a non-selective beta blocker, what's going to happen when you're blocking those effects? If we're blocking those receptors, you can get some really serious life-threatening bronchoconstriction, and that's really dangerous in our patients with respiratory conditions like asthma or COPD. So we want to be really cautious about this class of medication with those patients. Awesome, awesome job. The way you can remember is you have 2 lungs, so beta-2, 2 lungs. I remember that from school from way back when. And then the other thing to know about this class of medication, you really don't want to stop it abruptly, just because patients can fall back into that arrhythmia that they were initially prescribed this class of medication for. So you really want to taper off of it and see how they do symptomatically. Watch them pretty closely. And then you also want to watch for bradycardia. So you want to make sure that their heart rate is not slowing down too much and then causing other complications. So we want to make sure we hit the right balance or stride with that. Okay, before we jump into our case study, if all that was, let's take a little brain pause and say, I know that was really high level overview of those classes of medications. And if it felt a little bit too much, just remember you can always make notes like we talked about in the beginning and go back and study more on those particular classes of medications, go back to the pharmacology and really understand the pathophysiology of all of it. I pulled in some questions from the question bank. There's a free trial on that, so you can always practice in the question bank. It has a readiness predictor, so you can really identify those areas that you need to go back and study a little bit more about. And then our on-demand videos can help you with that in-depth coverage. So take a minute and just know that you're not in it alone. We at Archer really are building out this content for the whole nurse and trying to make sure that we're listening to our students and building content that's going to be relevant to you. So it's very student driven. Our CEO is a huge advocate of that. And so if you guys have feedback, things you want to see more about, I have a little poll at the end that you can tell me or you can put it into the chat. But our goal is to really help support you in whatever content that you need and make sure that you know that you're not alone. You have a community of nurses and nurse practitioners here that are here to support you in that journey. So don't get overwhelmed, make your notes, and then reach out if you need our help. Okay. So let's go into our first case study. Here's our friend John Doe. He, nice guy, 58-year-old male, and we'll give you a couple things about his background, and then I'll open up the slide and you guys can tell me what you think. But John comes in. He is a 58-year-old male. He's about 5'9", 220 pounds, a little obese, so there's some things that we can definitely work on with our friend John, but very pleasant, happy to be here. You've seen him a couple of times now. You know his medical history. He's a type 2 diabetic. You diagnosed him 5 years ago. You guys are working on that. He's also been diagnosed with hypertension and hyperlipidemia. You are an astute clinician and you've asked him about his family history, and you know that he has had a father who had type 2 diabetes and died of an MI at age 62. So our friend John at 58, we definitely want to make sure we keep his heart healthy so that we're not repeating history in his family. We already see here that his lifestyle is not ideal, right? Mostly sedentary, consumes a large amount of high caloric foods, minimal physical activity. A little bit more about his history. We know the medications he's on. He comes in today saying, you know, at home, I've actually noticed that my blood pressure has been a little bit high. So in the office, we're also seeing that his blood pressure is high. So he's at 160/98. Other vitals look fine. Taking a look at his list of medications, we see that he's on Metformin 1,000 milligrams twice daily. So he's maxed out on his Metformin. He's already on an ACE inhibitor. So he's on lisinopril 10 milligrams once daily, and he's already on a statin, atorvastatin 20 milligrams once daily. And then we see that he actually brought in his home reading. So John's a really compliant and helpful patient, right? You've worked with him for the last 5 years. You've talked to him about being his own healthcare advocate and really coming in with things that he's worried about and red flags. So he's come in with his home blood pressure readings for you to look at. And so here are a couple of readings from the last month that he's been able to document at home. So going into our next poll, what do we think John's blood pressure should be? So what is our goal for John? Remember, he's a diabetic. He, along with the hypertension, he also has hyperlipidemia. What should be our blood pressure goal for John? And I love these word clouds because as you all type the same thing, it just gets bigger and bigger. And so I'm seeing a giant font for less than 130/80. You guys are absolutely correct. And why is that? Again, he's a diabetic, and we really want to preserve not only his macrovasculature, like his heart, eyes, kidneys, we want to really be preserving his cardiovascular system. So we're going to be a little bit more aggressive, and the guidelines have become a little bit more aggressive too. So we really want to get him less than 130/80. Awesome job, you guys. So we do our assessment. We're going to listen to John. And we can observe that he's overweight. I do like to put that in my chart as I'm going through because it really does personalize my physical exam to what I'm seeing for my patient, gives a better overall clinical picture. So he's overweight, he's not in any acute distress. We're listening pretty closely to his heart, right? So I want to make sure that I'm not hearing any irregular rates or rhythms, no murmurs, but everything sounds good for John today. His lungs are clear, he's got no lower leg edema, and he's otherwise doing fine. So no focal neurological deficits. He's alert and oriented. So you asked more history questions, and he's also been asymptomatic. And so what are our initial thoughts with John? How is he doing? And I'm going to launch our next Slido for that. And this is going to be open text. So you guys can tell me, what do you guys think with John? What are our initial thoughts with him? What do we need to do? What are we worried about? What are some red flags that are jumping out at us today? Is he doing well? Is he doing some things well, some things not so well? How's John doing today? I see a lot of typing. That's good. Guys are thinking deeply about this. Yes, I love that. You guys are looking at John holistically. This is beautiful. So first and foremost, we need to make some medication adjustments to get his blood pressure under better control, because now he's shown us at home it's staying high too. This is not just a one-off in the office today. We're lucky that he's not symptomatic, right? He's still feeling well, but his blood pressure's been high. Absolutely. And then you guys are putting in a lot of lifestyle modifications as well. That's great. Yeah, he needs to be losing weight. He needs to be getting more active. Let's talk about that. Somebody wrote, ask more open-ended questions. How's his mood, depression? I love that. Awesome, awesome job. You picked up on that. I didn't put it in today's case study, but I was going to loop our psych meds into John too, but then I went a different direction. But yes, you want to be asking what's going on. Ask some open-ended question. How's he doing, right? Why has his blood pressure been going up? Very good. Seeing a lot of great answers. And then yes, check his blood sugar, his lipid profile, medication management. You guys are on point. Look at all these safe, effective clinicians. I love it. So absolutely, you guys hit the nail on the head. We want to get his blood pressure down, less than 130 over 80. We talked about that. That's what the current guidelines recommend. We want to reduce his cardiovascular risk. We want to assess his blood sugar control. So awesome job. A plus, you guys, you got that. We want to assess his lipid profile and improve on that. Very good. We also want to enhance his medical management. Yes, and then address those modifiable lifestyle risk factors like promoting weight loss, increasing physical activity. Awesome, awesome job. Are we going to do all this in one visit? No, absolutely not. I mean, this is something that we're going to be working on with John over many, many months, right? We don't want to overwhelm him. We're going to be tackling the lowest hanging fruit, and that's going to be some medical management today. Talking to him a little bit about some other things like getting some blood work done, and also talking a little bit about those lifestyle modifications, but we're not going to be tackling all of it today, right? It's going to be over several visits, and that's the beauty of primary care. We really have the opportunity to establish these long-term relationships with our patients so that we can work with them to help them feel like they're setting goals and meeting goals. So that's really important. So what can we tackle today? What should we do during today's visit? You guys kind of already answered this, but what do we want to prioritize today at today's visit? What is that low-hanging fruit for John? See a lot of typing, a lot of thinking. Let's see if we can agree. I should have maybe made this one a word cloud to see if we all agreed to this one. Yes. Yeah. So medical management of his blood pressure is our priority during today's visit, lowering that blood pressure and then ordering labs and talking to him about lifestyle modifications. You guys read my mind. Beautiful. All right, make sure you can see the right slide. So medical management, we're going to adjust his lisinopril. We're going to increase it to 20 milligrams daily. Remember, he's on 10, so we definitely want to bump that up a little bit. We can add that second agent, hydrochlorothiazide. I always like to start with that 12.5 daily just to make sure that we don't go too low. Remember, with those ACE inhibitors and those diuretics, they really work really well together in bringing the blood pressure down. So old school of thought was max out one agent and then add a second agent, but then you're kind of in this limbo of like, okay, now I have to bring the first agent down a little bit so I can add that second agent so our patient doesn't tank. What you could do is really make a small adjustment in that lisinopril and then add on a little bit of that diuretic with the hydrochlorothiazide. That's what I would personally do in clinic. So get him on lisinopril 20 and then put him on hydrochlorothiazide 12.5. Now, with all that said, this is an open conversation with John, right? Because some patients would prefer to max out that first agent and take one medication as opposed to taking two medications now. So this is really, you have to be mindful and present the options to your patients and let them make the choices. That's going to really help with compliance, right? Because if they're not willing to take two medications, then you've just basically bumped him up to lisinopril 20 and that's it. And that's fine too. We're going to have him come back and we're going to check, but you've prescribed a medication that he's not going to take, right? So it really has to be dialogue, an open dialogue with your patients. And that's where the trust and the relationship building comes into play. And then of course, as we continue to have him come in for follow-ups, if it's still not under better control, we can then consider adding a third agent, maybe a calcium channel blocker like amlodipine. Other things we can tackle today, and you guys already said it, we're going to be ordering those fasting labs. I should have a poll in here. I added a lot of polls for you guys today, but which labs are we going to be ordering? Let's see. Let's go to our next poll. You guys can type that in, but which labs will we be ordering for John today to have ready for us by the time he comes back? I see a CBC, lipid profile, chem panel, CBC. Yeah, so you guys are hitting the nail on the head. So at the very least for John, I'm going to be looking for what he's due for, right? But I definitely want to get a chem panel and a lipid profile in that CBC, right? I'll probably throw in an A1C, and I saw somebody threw that in there because remember, he's a diabetic. So if he's due, if it's been longer than 3 months, I'm going to get the whole picture and figure out how are we doing with our blood sugars and our lipid panel and our liver, kidney function, electrolytes. We're going to look at all of that. So we're going to have him come back in for fasting labs and get a CBC, chem panel, lipid profile, and an A1C. Those are going to be basic or the definite ones we'll get before next time. And then I'm also going to advise John to start checking his blood sugars at home if I see that A1C is really out of range, and bring that to the next visit too, because remember, he's actually doing a really good job. He's a pretty compliant patient. So we want to make sure that we're working one-on-one on a one-on-one case scenario with our patients. And if he's doing a good job with checking his blood pressure at home, then I also want him to check his blood sugars too and bring those in because that tells me a lot too. So let's get some fasting blood sugars as well. But basically, we want to reinforce those lifestyle modifications. We'll probably keep chipping away at that at every visit, right? One day he might come in and really want to focus the entire visit on those lifestyle modifications. But for now, we're just going to plant the seeds until he's really ready to talk about that, but encourage him to really be looking at his diet, eating healthier, getting more exercise. And then maybe one day he'll feel like he can open up about why he doesn't do those things and what those barriers are. And maybe it could be mood, right? That would be great. But we want to plant the seeds for now. We'll talk to him about the medication adherence. So how to take the new medications, what are some potential side effects? What are some things that he needs to call back about? And then praise and encourage him. He is doing a really good job being his own advocate. He's coming in with those home blood pressure readings. He's going to be doing those blood sugar readings for us now. So really giving him a lot of credit for how much work he's doing for himself. So that's awesome. All right. So let's go to our next section, being mindful of the time. So these case studies are always really fun, but it definitely takes a lot longer than one usually maps out for. Because when I'm putting these together for you guys, it's typically faster in my head. So it's good to know as I'm starting to build this series out about what to include and what to take out, just to make sure that it's moving more quickly through the presentation. All right, this one we're going to read together, but I have opened the poll. So if you've read it and you're ready to answer, you can go ahead and answer what you think is right in the poll, but let's read it together on the slide. A patient with type 2 diabetes has been taking oral medications, but their A1C remains elevated 9.5%. The patient weighs 199 pounds. The nurse practitioner is starting insulin, so they're telling you what type of insulin. It's Lantus. The nurse practitioner will correctly dose this as which of the following? So is it A, B, C, or D? So again, safety first. They're trying to make sure that you know what Lantus is and how to prescribe it safely. So are you going to be starting at 5 units sub-Q before breakfast and at bedtime? Are you going to be starting 5 units sub-Q at every meal? You're going to start 10 units sub-Q every 24 hours or 18 units sub-Q every 24 hours? What do you guys think? A, B, C, or D? And I'll leave the poll open so you guys can see each other's responses. So I see a couple of debating back and forth. I like that. Sometimes it just comes down to 1 or 2 responses and it's hard to pick. All right. So oh, you guys are still participating. It's okay. That's good. I love to see you guys putting in responses. So the right answer is C. So we would be starting this patient on 10 units every 24 hours. And let's go back to the slide. So if you're in our Q-Bank, it will give you the explanation like this. I'm going to talk through it with you. So remember, Lantus is a basal, long-acting insulin. So we would be giving it every 24 hours. It's not a prandial or short-acting insulin. So we're really not giving it at meal time. So you could have already eliminated A and B as your choices because those were too short term, right? You have to really be looking at the peak and how long the duration is of the different insulin. And we'll go over that in the next chart together. The 2 tricky ones, which I didn't really see you guys fall for, which was pretty good. Typically people will fall for this one, was between C and D. Because you knew that Lantus, long acting, it can last 24 hours. So you're not going to be prescribing it more than 24 hours. But do you start this patient on 10 units or do you start them on 18 units? And I think the trick was that they gave you the patient's weight. So if you knew the calculation, you knew that this patient would probably eventually need 18 units of insulin a day. However, the safety around this question is that you would never start a patient on more than 10 units a day because you really don't want them to tank, because that patient is going to be really insulin sensitive. As soon as that body has been so insulin deprived, gets the insulin, you hit them with 18 units, they're going to tank, right? So we would never be giving more than 10 units of insulin a day. In our pediatric patient population, that's even way less depending on the age, but we're talking about an adult patient. Now, this patient, like I said, you might be right with the calculation, may eventually need 18 units a day, but we're going to gradually titrate them up by 1 to 2 units every 3 days and see how those fasting glucose levels look in the morning. So that's the explanation as to why C, this was the correct answer, with starting that patient on 10 units every 24 hours. So this is a nice little graphic that Archer has put together about insulin. It really goes through the onset, peak, and duration of the different types of insulin. In my mind, I'd like to group them in three different ways. We have our short-acting and our rapid-acting insulin in one group in my brain. I have that intermediate-acting, which we really don't use in clinical practice anymore, and I'll talk to you about why. And then we have our long-acting, like Lantus, which was in our example. So remember, with Lantus, onset takes about 2 to 4 hours. Doesn't really hit a peak, but it lasts 24 hours. So you would never be giving this at mealtime 3 times a day or even twice a day. I see some providers, some really old school providers still prescribing it twice a day, and their rationale is, well, it just works better that way. No, it really doesn't. You just need a short acting insulin on board at that point, along with your long acting, right? That's what's going to be more helpful. So long acting lasts 24 hours. Now with our rapid acting and our short acting, the onset is much faster, right? Rapid goes with its name, 15 minutes for onset, short acting 30 minutes for onset. So within 15 to 30 minutes, we start to see some effect, but it really doesn't peak for at least a few hours, 1 to a few hours, right? And this is going to be a big point to stress with patients, especially a lot of times with my type 1 diabetics, we get a lot of what we call insulin stacking because they get so hypervigilant about their blood sugar levels. And so what ends up happening is they'll give themselves insulin, they'll check in a couple hours, they're not at the goal range that they want to be, so they'll give again. And then what ends up happening, that peak is stacked. So once that first round starts to take effect, then that second round takes effect and they start to tank. And then they have to play yo-yo all day with eating, bring those blood sugars up, you spike, and then you give, you stack again, and then you tank again. So then you're kind of up and down all day. So you really want to make sure you're stressing with patients. Yes, it takes effect pretty quickly, but its peak is not for a couple hours. So just wait and don't give again, right? We're going to wait after we give our short acting or our rapid acting insulin. With those patients, we typically will switch them over to rapid acting if their insurance will cover it, just because it does, the onset and peak is a little bit faster, just because they're a little bit more impatient about it, just to help prevent that stacking. But you really have to educate these patients. But look at the duration, it's really on average about 5 hours. So this is going to be more your mealtime or your prandial insulin. Now with intermediate acting and pH, why don't we really use it anymore? Well, look, the onset is a couple hours. Its peak and its duration is really highly variable. So some days it might peak in 4 hours, other days it might peak in 12 hours. Some days it might last 10 hours, some days it might last 24 hours. So really with NPH, we see a lot of variability in blood sugar levels. So we really aren't using these intermediate acting insulins anymore. So think about it in those 3 groups. I think that'll help you. And then take a picture of this graphic that Archer has put together because it's really helpful when you're going through those practice exam questions. Okay. So now getting into the oral medications, and I want to make sure everybody got a picture of this graphic. Yes, we're good. Okay. So now going into the oral medications, Metformin is our only medication in the biguanides class. It's, if you've heard me lecture on diabetes medications before, and Sam has heard me probably lecture and say this a million times, but I love Metformin. It's a great medication. It's cheap, it's safe, it's effective. It has a fairly low side effect profile. So making sure as clinicians, we're getting patients on this class of medication or on this medication properly to help minimize those side effects and get patients to stay on this medication is going to be really important. How does it work? What's the pharmacology of metformin? It really decreases the absorption of glucose in the intestines. So that's why we get a lot of that GI side effect, right? Look at the pharmacology. It'll tell you about the side effects, the contraindications, the dosing. That's also why we dose really slowly. We start low and go slow to help minimize those side effects and really tell patients to take it with their biggest meal. And we're gradually going to titrate up. I don't even care about going up every 1 to 4 weeks. I'm literally going to start them at 500, go really slow and keep them there for a while just to get them to get their body used to the medication and stay on the medication. Because I see some patients getting started on maximum 1,500, 2,000 milligrams a day, and they'll have really bad GI side effects. They won't take it, and they'll say, put that on my chart. I never want that again. And that's really a shame with this medication because it really helps on a cellular level. So with that lock and key mechanism, moving that glucose out of the bloodstream and into the peripheral tissue, it really helps with that, enhance that uptake. So it really works on that cellular level. And it also works through the liver with that hepatic output. It reduces the hepatic output of glucose in the liver. So that brings us to the contraindications. We want to make sure that the patient doesn't have any severe hepatic dysfunction because it does also work in that context. And then we want to make sure that they can excrete it so there's no end-stage renal disease because we want to avoid buildup of lactic acid. So we want to avoid lactic acidosis, which is a pretty low risk. But there was another medication called fenformin previously available in this class, and it did get removed because of the association with lactic acidosis. So we just want to make sure that we're not falling into the same issues with metformin. Then we have our sulfonylureas. These are our medications that end with "ide." And so this is going to be your glyburide, your glipizide, glimepiride. And how do these medications work? They help really increase the release of insulin from those beta cells. So that really helps us identify that this is going to be contraindicated in those type 1 diabetics who just don't have those functioning beta cells. It also increases the insulin sensitivity. So we're going to see a lot of hypoglycemia associated with this class of medication. That's going to be the biggest thing, right? Then it also helps decrease that glucagon secretion from the liver. So we want to be looking for any liver disease, renal impairment. We want to make sure we can clear it. And then it's contraindicated in pregnancy and breastfeeding. Sometimes you just have to memorize those. It also does contribute to weight gain because, again, it really helps that lock and key mechanism. So it's doing a really good job with moving the glucose into the cells. So if the body's getting enough of that, it's going to start storing it for later for when it's deprived. So it's going to store it into adipose tissue. So we do see a lot of weight gain with this class of medication as well. But definitely want to be making sure we're taking it with meals. We're not skipping meals because of the big hypoglycemic risk. With our thiazolidinodoins, I can never say this, I'm sorry. We call them TZDs. Here's the suffix, the glitazones. You have Avandia and Actos. And so the pharmacology with this class of medication, it does help really improve that insulin sensitivity. Biggest side effect, it increases the reabsorption of water through the kidneys, and that's why we get all that fluid retention. And that's why it's contraindicated in our patients with heart failure, because we really do get, the way it works, the mechanism of action increases that reabsorption of water. And so with the fluid retention, it can exacerbate those heart failure symptoms. So you have to really educate patients on signs and symptoms. And if they develop any, you need to stop the medication. They need to call your office right away. And we just would not initiate it in patients who already have known heart failure. It also does cause weight gain because of that fluid retention. So maybe not the best class of medication, someone who's really trying to work hard on losing weight, and that's a big sore point for them. With our SGLT2 inhibitors, those are our glyphosozins. When you've been in clinical practice for a long time, you start to really get used to the brand name. So I'm sorry if I'm butchering some of these suffixes, but you'll see the gliflozin. So that's your Invokana, your Farxiga, your Jardians. This class of medication, it mostly works in the kidney, so it really decreases the absorption of glucose in the kidneys, which promotes a lot of glucose excretion in the urine. When you have glucose, those large molecules leaving the urine, it's also going to take the water with it. So you get a lot of increased urinary output as a side effect of these SGLT2 inhibitors. With that, because you're losing all that glucose as well, and it's in a nice little warm breeding ground, you really have to watch for infection. So any kind of yeast infection on the skin or UTIs, you want to be mindful of that. We do a clean catch urine on our patients who are on SGLT2 inhibitors, and you want to definitely screen for that when they come in, make sure there isn't an underlying infection. In our elderly patient population, this is the class of medication that I will take off first because of that volume loss. And so I want to really be avoiding hypovolemia and dehydration in our older patient population. So something that I would be taking off first as we're loosening on those A1C A1C goals. But great class of medication, expect to see high glucose levels in their urine, but you want to be watching for those ketones, blood, and make sure there's the leukocytes and make sure there's no infection. Ask those questions. All right, our GLP-1 agonists, these are the ones that are really, really popular right now for weight loss. It did start as an anti-diabetic medication. And so you have both oral and injectable options, but you've probably heard or had patients come in asking for Wegovy and Zepbound, and you'll see a lot of semaglutide compounds. These work, so the GLP-1, its role in the body is to really respond to food intake. And so when you eat, it stimulates the release of insulin. GLP-1 also slow the gastric emptying and decrease the glucagon secretion from the liver and also increase satiety. So the patient's less hungry. So that's what GLP-1 does in the body. When you have an agonist, meaning you're enhancing the effects of GLP-1 in the body, then it's going to help promote all these things, meaning it's going to stimulate the release of insulin. It's going to slow that gastric emptying. It's going to decrease the glucagon secretion and help satiate that patient. They're not as hungry. So all those things are how it works. So of course, the side effects are going to be mostly GI, and we want to watch for pancreatitis because of how it really works predominantly in that GI tract. Contraindications would not be starting patients who already have known gastroparesis or delayed gastric emptying issues on this class of medication because they will end up in the hospital with an obstruction. So you just want to be really careful about that. Other biggest red flag for this class of medication is that risk of thyroid cancer. So if they have a personal or family history of medullary thyroid carcinoma, this is a big no-no. And of course, you can't have pregnant patients on this medication or breastfeeding moms. And then our last class before we jump into our case study for our anti-diabetic medications are DPP-4 inhibitors. These are our gliptins. So this is your Januvia or your Tradjenta. DPP-4, let's think about what DPP-4 does in the body. It inhibits the GLP-1 peptides that we just talked about. So if we have a DPP-4 inhibitor, so if it's stopping those DPP-4s, then it's allowing for that GLP-1 activity. So that's why I group DPP-4s and GLP-1s in my brain. The pharmacology is really pretty identical to that GLP-1 activity. It increases that GLP-1 activity. So again, it stimulates the release of insulin, it slows that gastric emptying, decreases the glucagon secretion, increases satiety, and you're going to get a lot of GI symptoms. Now with DPP-4s, it is contraindicated in our type 1 diabetics. Again, it works the same in GLP-1s. Insurance won't cover GLP-1s in our diabetics for diabetes, but you might be able to get it covered for weight loss. But the reason for that is, again, it stimulates that release of insulin. So if you're just not, if you're a type 1 diabetic, it's not going to work for you in that same sense. But these are kind of expensive, and you really have to watch insurance to see what's covered, what's not. All right, so going back to our friend John, he comes back in for his follow-up visit. So remember, he's a type 2 diabetic. We saw him for his hypertension at the last visit. We ordered some labs for him. So let's see how he's doing today. He comes in today and he's more symptomatic actually now. So he's complaining of fatigue. He's now experiencing more frequent urination, increased thirst. He started to monitor his blood glucose levels like we asked him to, and he's noticing that those are consistently high. So good thing we started talking to him about that and working on that, but his fasting glucose levels are averaging between 180 to 220. Remember, we started him, or we bumped up his lisinopril, so he's now on lisinopril 20 milligrams once daily as opposed to 10, and we added that hydrochlorothiazide 12.5, and we can see his blood pressure today is looking great, and he's reporting that it's under goal, under 130/80 at home as well. Now, looking at his diabetic medication, he's still on just metformin, 1,000 milligrams twice daily. He's tolerating that well, no side effects, he's doing fine. And he's on atorvastatin 20 milligrams once daily. Oop. So what should his fasting glucose levels be? I'm going to launch our next poll. But as he's coming in and he's telling us his fasting blood glucose levels are averaging between 180 to 220, what should we be thinking about? What is our goal for his fasting blood glucose levels? And this is an open text, I believe. So you guys can just enter what you're thinking, and I see some typing. Yeah, seeing a lot of similar responses. Very good. So the ADA recommends for this patient, we really try to get his fasting blood glucose levels to range between 80 to 130. So less than 130 ideally, and then we don't want him to go too low. That's very good. Awesome job, you guys. So remember we ordered those labs, so we did get an A1C on him and it's 9.2%, which is not surprising given his fasting glucose levels. His lipid panel, his LDL's come back and it's at 120. HDL, so he's still pretty sedentary. So HDL is only 38. And then his triglycerides are 220. So he's still eating a poor diet, high caloric diet. We're going to talk to him about that, but that's not really been his focus yet. He's just been seeing his blood sugar levels and working on that at home. All other labs looks great. Kidney function still looks good. All that is still well preserved. So I'm going to open our next poll and you guys can enter what you think. We're going to go back here. And what are we going to do for John today? So you guys can keep entering your responses. Make sure I open the right poll, but what are we going to be doing at today's visit with John? So we now have him coming up for a follow-up visit and we're managing all these different things for him. What are we going to focus on during today's visit? What are some initial thoughts? I'm seeing some medical management, working on his blood glucose levels, blood sugar levels, continue his blood glucose monitoring at home and add maybe a second agent to his medication today. Very good. And this might be the visit that we're really talking to him about his diet and his lifestyle. Absolutely. Yes. So what's going on? What's keeping him from eating a healthier diet and getting more activity? Yeah, very good, you guys. So a lot of lifestyle modification, continued lifestyle modification, and medication management. But mostly I'm seeing the same answer. We're going to be tackling his diabetes today, and we're going to be talking to him about medical management of his diabetes. Very good. So we've assessed his diabetes. He's not adequately well controlled on his current regimen. His A1C is well above goal. Remember, we're trying to get him down to 6.5% or under 6.5. Certainly his fasting blood glucose levels are not at goal. And he's symptomatic, right? He's showing some classic signs of hyperglycemia. So he's starting to really experience fatigue. Some of that may be because we're now bringing his blood pressure down, but really with a diuretic and an ACE inhibitor, fatigue, I'd chalk that more up to something, his heart is definitely working a little bit harder because of those high blood glucose levels. And so he's frequently urinating, and that increased thirst really tells me that it's more his blood sugar levels are too high. And his poor lifestyle choices. So that's making things worse, right? He's sedentary, that high diet, minimal physical activity, he's going to feel more tired, and that's not going to help his blood sugar levels. So where do we start today? You guys kind of already said it, so I'm going to skip past this poll, but definitely with medical management and discussing lifestyle. So which medication would you add? And I'm going to go to the next poll where you can free text in that one. But which medication should we add as a second agent for John today? What do you guys think? Make sure you can see my correct screen. I see some typing. Good. But what are we thinking about for medical management? So he's on metformin. He's maxed out on metformin. I love that. If insurance allows, Jardians, very good. Yep. Sometimes it doesn't matter what we want to start them on. It's really going to be directed by insurance. So I see order a CGM, very good. So if any of you have had the opportunity to use CGMs, those are continuous glucose monitors in your patients. They're really a game changer. They have CGMs or continuous glucose monitors where patients literally don't even have to think about it, and all the data goes to their phone, to their app, and it goes to you when you set it up in your clinic as well. So you can really see how their blood glucose levels are doing. And that's really nice because if insurance covers it, then they don't have to be checking their own fasting blood glucose levels every morning, and you can get a really accurate picture of what's happening with their blood glucose levels. So I love that. Yes, order CGMs. It's not always something that's going to be covered by insurance, and they are pretty expensive. But if you're working in endocrinology, oftentimes we'll have samples we can give patients for free, and we have little tips and tricks up our sleeves. But I know that's state specific too with what you can do with samples, but absolutely. So assess what he wants to do, injection med or another oral medication, but seeing a lot of great critical thinking happening here. Very nice, you guys. So what would I personally do with our friend John? Remember, this is his list of medications. We want to continue the metformin. I love metformin. I've been singing its praises. I swear I don't have any stock in metformin. I just think it's a great medication. For me personally, I would add a SGLT2 inhibitor like Jardians, and somebody already said that if his insurance does cover it. That's absolutely what I would do as well. So great answer. Remember, SGLT2 inhibitors, and I didn't stress this during the slide, so it's reminding me of my train of thought now, but SGLT2 inhibitors now have been approved in patients who aren't even diabetic because of the cardiorenal protective property. So you can use it in your heart failure patients or patients that you really want to really protect their heart from remodeling. So we're going to see it a lot more in primary care practice, but for John, because he has the cardiac history and he has diabetes, an SGLT2 inhibitor is going to be a really great class of medication to get him on. Especially since he's young, he can tolerate that hypovolemia, right? All the urination. You just have to educate him on it, make sure he's aware of the side effects, and he's monitoring for infection, and you're monitoring for infection as well. But it also helps him with the weight loss. A lot of it initially is water weight, but research shows that eventually it's also adipose tissue. So I think SGLT2 inhibitor, if we can, for John, would be a really great second medication to get on board. And then, of course, if he's still not well controlled, then we can consider getting him on a GLP-1 or a DPP-4 inhibitor down the line. Again, those are also expensive, also may not be available in pharmacies. So my next plan would be to get him on a SGLT2 inhibitor. Awesome job, you guys. So biggest thing to stress with him at this visit is how to take the medication, potential side effects. We always want to talk about hypoglycemia awareness. What does that mean? It means helping patients identify the signs and symptoms of hypoglycemia before they become severe and what to do about it. So that 15 grams every 15 minutes rule, right? And if that's kind of over your head, just make a little note. You can go back and watch one of my previous lectures when I talk about hypoglycemia. We won't go into it today, but you definitely want to make sure that you're talking to your diabetic patients about hypoglycemia and documenting it in your chart. We also really want to reinforce those lifestyle modifications. Again, maybe he's ready to talk about it and dive deep today. Maybe you're just planting the seed again today, but we really want to continue to plant those seeds and work with him on that and give him some praise and encouragement because he's doing a lot of work at home for himself, right? So he's doing a pretty great job. Awesome job, you guys. Very nice. I love it. So hopefully you guys are enjoying these case studies, but I'm enjoying going through these case studies with you guys. I think it's a lot of fun and you guys are doing great. I'm going to launch our next poll for this in case you read faster than I do, so you can answer the question. So the poll is launched and we'll read through the responses together, read through the practice exam question together. So switching gears to another section. Which of the following patients should be prescribed a long-acting muscarinic antagonist, also known as a LAMA, for asthma? Is it A, uncontrolled asthma and emphysema taking medium dose Symbicort daily, so that's your budesonide and your formoterol? Is it B, symptoms of asthma 2 times per month as your initial therapy? Meaning you would be starting the LAMA as your initial therapy for a patient who has symptoms 2 times a month? Is it C, symptoms of asthma most days of the week, taking albuterol or ProAir as needed? Is it D, daily asthma symptoms, taking low budesonide or formoterol, also known as Symbicort, one of the brand names, daily? So what do we think in a patient? When would we start a LAMA for our asthma patient? Is it A, B, C, or D? And I'm seeing some great responses. I'm seeing some people are thinking about it. Remember, these responses are anonymous. It's a great way for you to practice and see what your peers say. We're kind of getting an equal response across the board right now, getting a couple more responses. Let's think about it. Okay. So most of you said D, daily asthma symptoms, and they're on low dose budesonide formoterol already daily. The correct answer is A, which about 38% of you got right. So in a patient with uncontrolled asthma and emphysema, already taking a medium dose budesonide formoterol daily, that is the right answer. That's when we should be thinking about prescribing a LAMA. And let's talk about why that's right. So a LAMA is going to be first line in a COPD patient, so we can already eliminate choice B, right? In a patient who's having symptoms 2 times per month, this is really intermittent severity asthma. So this question is really trying to gauge, can you grade or classify the severity of this patient's asthma, and what do the GINA guidelines say? When are you going to be prescribing a LAMA in an asthma patient? So B, we can eliminate right away because it's never used as initial therapy, especially not in a case where the patient has intermittent asthma. So B is a no. Let's go, I'm going to go one by one. So C, symptoms of asthma most days of the week, and they're on albuterol as needed. So what can we do between albuterol and before we jump to a LAMA, right? So the new GINA guidelines say that we really want to try to get this patient away from those short-acting beta-2 agonists, which is what albuterol is. We want to get them more towards those long-acting beta-2 agonists like formoterol. It has a really nice long half-life, and so it really is quick to act, unlike other long-acting beta agonists, and it lasts a long time. In conjunction with a low-dose inhaled corticosteroid, and that's going to be used both as rescue and maintenance therapy. So C, in a patient who's just taking albuterol, there are a lot of other things we can do before jumping right to a LAMA, long-acting muscarinic antagonist, right? So then that kind of comes down to A and D, and that's where you guys were kind of, the majority of you were toggling back and forth, which is exactly right. Usually it comes down to 2 responses. And so let's look at D. So daily asthma symptoms, taking a low dose budesonide and formoterol daily. So this patient's having daily asthma symptoms. So we already know the severity is moderate to severe. We really want to make sure that this patient, their symptoms are coming down to less than, getting into that intermittent severity range. But they're on low dose budesonide and formoterol. So before we jump to a LAMA, we probably want to try a medium dose budesonide formoterol for this patient daily and see how they do before we jump to that LAMA. And that's why A, with a patient with uncontrolled asthma, they already have some emphysema. So we already see some remodeling of the lungs. We're seeing some air trapping. We're seeing some signs of COPD. And they're already taking that medium dose budesonide formoterol daily. this is a patient where we would want to be adding a LAMA, right? So this is going to be really important. This uncontrolled asthma patient, we're going to then add a LAMA. We already got them on that medium dose. So, and if you were doing it on our Q bank, let me go to the next slide so you guys can see. You'll see the answers and I'll give you the rationale. We just talked through it together, but that's basically what it'll tell you. And so you really learn a lot from our question bank as you're going through the rationale. And then you're like, you know what, maybe I need to go back and read a little bit more about the pharmacology of this class of medication. And then maybe I need to go review those guidelines a little more to better understand it. But you guys did great. It always comes down to two. All right. So let's talk about that beta-2 agonist, those ARBs, I guess, is the suffix that you can look at for the endings. We have our short-acting or our SABAs and our long-acting or our LABAs. And so indications, you can use this class of medication in both asthma and COPD patients. How does it work? It binds to those beta-2 receptors in the airways. Remember, we talked about the beta-2s with those beta blockers. So you have beta-2 receptors in those airways to help relax and dilate those smooth muscles in the bronchi to really help get as much airflow, open that airflow to combat the inflammation and the mucus buildup that happens in asthma. Biggest side effects, it can make some people feel more jittery. So it can cause some restlessness, anxiety, tachycardia. So you want to watch for that and see if the patient can tolerate it. It does have a lot of drug interactions as well. So you definitely want to watch for that biggest drug interaction with like glaucoma medications, because remember, it does dilate. So if you're already dealing with that, it can increase that intraocular pressure and worsen glaucoma. So you want to be really careful. Of course, beta blockers are going to be contradicting to the beta agonists. So that's going to be a drug interaction. And they can also cause that tachyphylaxis. And so it may not be effective if used frequently. So tachyphylaxis is when if you're using something frequently during short periods of time, then it's not going to be as effective as rescue therapy. And that's why we've really switched over to smart therapy and using more of a long-acting beta-2 agonist along with the inhaled corticosteroid. And then with our SAMAs and our LAMAs, these are our muscarinic antagonists. We have our short-acting and long-acting. And again, these are also indicated in both asthma and COPD, but it's first line in our COPD patients. These they're also used again in asthma as an add-on therapy, but like I said, in more severe cases when we've tried all the other routes. It blocks that muscarinic receptor in the bronchi and helps relax that smooth muscle and really helps decrease that bronchoconstriction. It also helps reduce that mucus production, which I think is why it's also first line in COPD and also still used in asthma. Biggest side effect with this class of medication, it does block that acetylcholine from binding to those muscarinic receptors. So it can cause dry mouth, dry skin, constipation, urinary retention. So contraindication, you don't want to give it in patients that may be already having some blockage issues with urinary issues. So in our BPH patients, or if they have maybe some bowel blockages, again, with glaucoma, you don't want to be giving it in patients that already have blockage issues. Again, it can cause that pupil dilation and worsen that intraocular pressure. And then with our glucosteroids, we can give this in both our asthma and COPD patients and often do. This really just helps decrease that inflammatory response. Those inflammatory mediators helps calm everything down, suppresses the inflammatory response. We have our inhaled agents as well as our oral agents. With our inhaled agents, the biggest takeaway is really talking to our patients about making sure they're rinsing their mouth and their throat after taking it, because it can cause those fungal infections. So making sure we rinse and gargle after we use it. Some patients also will notice some hoarseness or some vocal cord irritation as well with these inhaled steroids. With our oral agents, we really want to be watching for patients who have underlying diabetes because it can elevate their blood glucose levels. It also can contribute to fluid retention, other metabolic issues. So we don't want patients on oral agents chronically unless they're taking it for other autoimmune conditions and to suppress something that a rheumatologist has prescribed them for. So systematically, we really want to try to limit it to less than 7 to 10 days, ideally for any acute attacks. And then if you do have patients on more long-term therapy, we definitely want to make sure we're tapering them and we don't stop it abruptly. But it can cause adrenal issues, bone issues like osteoporosis, growth suppression. So we really don't want patients on oral steroids for a long time due to their side effects. All right, so let's jump into our case study. So today we're going to meet Amelia Bedelia. I was having a little fun with the names. If you guys have read the books as a kid, or maybe you have kids, you know the series. She's a 25-year-old female, so a little bit older than the girl in the series. She's 5'4", 140 pounds, BMI is in the normal range. She comes in and you've been caring for her for a little while now. You know a little bit about her medical history. She was diagnosed with asthma at age 12. She also has some allergic rhinitis. She's identified that it's with dust mites and pollen. That's been confirmed with testing. She has a family history of father with type 2 diabetes and mom with asthma. Social history, she's an elementary school teacher. I thought this picture, she definitely looks like an elementary school teacher, bubbly, having fun with the kids, non-smoker, no alcohol, no drugs, and she lives at home with a pet cat. She comes in today and she says, you know, I've been having more frequent asthma attacks and it's especially happening at night. It's waking me up at night. She reports using her rescue inhaler more frequently, particularly at night, about 3 to 4 times a week. And she's waking up coughing. So current medications, she's only on albuterol as needed. And again, she's using that about 3 to 4 times a week right now. And she's on loratadine, which is an antihistamine. And she's using 10 milligrams daily for her allergic rhinitis. Vital signs, blood pressure looks good. Everything looks good except for her pulse ox at 96% on room air. So let's go to our next poll and see what you guys think. So who's concerned about Amelia's asthma control on a scale of 1 to 10, 1 being not concerned, she's doing great, 5 being highly concerned. Who's concerned about our friend Amelia Bedelia and her asthma control? Looks like universally we're all concerned. Good. Our red flag should be up. Very good. She's telling you she's using her albuterol 3 to 4 times a week, right? That's not good. So what are some things in her history that we should be concerned about? And I just gave you one, but what do you guys think? You can free text here, but what are some things that we learned from her history today that concerns us about her asthma control? I see some typing. Yeah, she's waking up at night. She's only on albuterol. Absolutely. Cat as a pet. I love that someone picked up on that. Very good. Waking at night, coughing. Absolutely. So the coughing, those lungs are trying to open up, right? That's what that cough is. Cat as a potential trigger. Yes. A lot of people, as that word cloud gets bigger and bigger, the waking at night, the coughing, and the cat, and the frequent use of that Sabbat is getting really concerning. The cat as a pet's getting bigger and bigger. Very good, you guys. Awesome. Yeah, absolutely. So all those things, she's frequently using that Sabbath. She's only on a Sabbath. She's waking up at night. And this cat, where's this cat sleeping? I want to know. So you do your physical exam. She's alert and oriented. She's not in acute distress. You notice some mild nasal congestion, but really everything ENT is normal. Heart rate's feeling, listening sounds good. Regular rate and rhythm. No murmurs, no rubs. Lungs, we're hearing bilateral expiratory wheezing, no crackles. Is that an expected finding from what we're hearing about her history? Yeah, absolutely. Yeah. So let's go to our next poll. What are our initial thoughts on Amelia. Let's launch poll number 16. And this is a free text, so you guys can write what you're thinking, but how would you classify Amelia's asthma severity? So let's think about that initially, and then what would be your initial treatment plan for Amelia? And you guys can free text that in here. But let's talk about her severity first. How would you classify Amelia's severity? Yes, moderate to severe. Yes, moderate to severe. Absolutely, you guys. Yeah, and going to the next one, what are we thinking with what is our initial treatment plan for Amelia? So we've identified that she's in that moderate to severe severity range. What are we thinking? Add medication. What would we add? A long-acting, switch her over to a long-acting beta-2 agonist. Very good. Add an inhaled corticosteroid. Very good, you guys. Awesome, awesome job. Yes, absolutely. So our goal for Amelia is to really help reduce her symptoms. So we want to get her really into that well-controlled range, right? So less than 2 symptoms a week, less than 2 wakings a month. Right now she's having 3 to 4 a week. That's a lot. We want to help prevent these exacerbations in the future by educating her and getting her on the right rescue and maintenance therapy. And then we want to address those triggers. You guys, a lot of you talked about those triggers. So absolutely. So some medical management, what would I personally do for our friend Amelia? And you guys all spoke to this. We would add that inhaled corticosteroid. So I'd start her on budesonide, 180 micrograms, 1 inhalation twice daily. Remember, per GINA guidelines, budesonide, low dose, still under 400 micrograms a day. And we can start her on that low dose daily. That's what the GINA guidelines recommend for moderate asthma in her case. So we'd start her on budesonide, 180 micrograms, 1 inhalation twice daily. That's still under 400. We'd switch her over from that short-acting beta agonist to a long-acting beta agonist like formoterol. Ideally, if we can get her on a combination inhaler where she can use that just together instead of 2 separately, that would be great. Like a Symbicort, if we get her on a low dose inhaled corticosteroid version of that, that would be great. Oftentimes, that's going to be really challenging, especially I know with my patient population, their insurance really does not cover anything. So I have to really break it down into 2 separate inhalers. And so you have to work with the pharmacy. Hopefully the pharmacy is nice. And they can work with you to see what is covered under their insurance and get them on the right regimen. But you can get them on a combination with that Symbicort, 80 if you're doing 2 inhalations twice a day. Remember, that's 160 twice a day. So that's what, 320, still under 400, right, of that budesonide. So we're still in that low dose range. What about oral steroids, or oral glucocorticoids? What do you guys think? Does that have a place for Amelia today? Did I launch a poll about this? You guys can put it in this open text poll that I still have up. What would your initial treatment plan be for Amelia? What do you guys think about oral steroids in this case scenario? I love that. Remind her to rinse her mouth after using the inhaled corticosteroid. Very good, you guys. Yeah. I'm seeing some people write short bursts of relief with that oral steroid. Absolutely. Yeah. And so don't be afraid of using steroids for short bursts to really help get relief and get that inflammation down. Remember, airway, nurses thinking airway, first thing, right, is always airway. And in this patient, we're really hearing the wheezing when we're listening on exam. She's having symptoms 3 to 4 times a night. It's going to take a while to get her on this new regimen with the inhaled corticosteroids and the long-acting beta agonist, because Lord knows with insurances and pharmacies, I would absolutely get her on a short course to give her relief and keep her out of the hospital. So I'd start her maybe on prednisone 40 milligrams for 5 days, counsel her about it. So she should really take it in the morning. Some people feel really jittery. They don't sleep well on the medication, but she really should be feeling better, right? Her airways really should be opening up. You could also, it's a gray area. You can also ask more questions. How much is her asthma really limiting her activity? And are there signs of severe airway obstruction? You can kind of gauge whether we need some more immediate relief. In my professional opinion, I would absolutely get her on a short course to get her feeling better more quickly as we're getting the new treatment regimen on board. Very good. Okay, you guys. So what are we going to focus on again with our friend Amelia Bedelia? We're going to assess it case by case, and we're going to talk to her about her new medication. So a lot of you talked about rinsing the mouth. In this case scenario, she doesn't necessarily need a spacer because she's an adult. We want to be thinking about that with our pediatric and our elderly patients. Talk about those potential side effects. Educating patients on self-monitoring. So really developing a written asthma action plan with Amelia is going to be really beneficial for helping her recognize exacerbations and keeping her out of the hospital and safe at home, right? You're going to teach her how to adjust her medications as needed and how to look out for those warning signs. Some environmental modifications that you guys already called out. The cat is a big trigger, right? So make sure the cat is out of the bedroom. Make sure that she's using HEPA air filters. So HEPA stands for high efficiency particulate air filters, some fancy name, but basically it helps remove all those particles up to like 99.9%. I had to look it up. I was like, how effective are these? It's really effective. So get those air filters in her house or apartment or wherever she is. And then her sleeping state. She's waking up with these nighttime symptoms. So dust might proof her pillow and her mattress covers. We should all maybe be doing that. Washing the bedding weekly in hot water, but really talking to her about her modifying her environment and identifying those triggers and setting herself up for success is going to be really important. You guys, a lot of you hit the nail on the head with that. Great job. Okay, so let's go to our next section, and we're going to go to our next poll. You guys can read it, answer it if you're a little faster than I am. So a patient is found to have vitamin B12 deficiency. Which of the following medications taken for chronic conditions should be evaluated as a potential cause? Select all that apply. Is it A, B, C, or D? What do you guys think? Absolutely. Across the board. Look at you guys. Very good. I'm not gonna allow as much for the polls. I'm sorry, just because of time. I really want to get you guys this content. So absolutely, omeprazole and metformin, so those PPIs absolutely can cause that malabsorption of vitamin B12. So let's jump in. And so this is what, if you want an in-depth explanation, our QBank will give you that. I'm going to jump into the PPIs just for the sake of time. So our proton pump inhibitors, those are the prazoles, so like our omeprazole or pantoprazole. Indications, lots of different indications can be used for ulcers, GERD, H. pylori treatment, but how does it work? It really blocks that acid secretion by blocking that proton pump enzyme in the stomach lining. Biggest things we need to be looking out for with this class of medication, you want to educate this patient to take it really 30 to 60 minutes before meals to allow for it to work before the stomach starts secreting that acid. And of course, it has a lot of drug interactions, so you want to be mindful of that and look that up every time when you're prescribing and counsel patients on any warnings or red flags with abdominal pain or any of that black tarry stool. With our H2 receptor antagonists, those are our TZDs, so that's our famotidine or ranitidine. Again, lots of different indications, but can be used for ulcers and reflux. How does it work? It blocks that acid secretion by blocking the release of those histamines that are found in our GI mucosa. Again, with this, biggest side effects, slows things down, so it can cause some constipation, some GI discomfort. But biggest thing with our elderly patients and our patients with renal impairment, we want to really be looking for any signs of CNS impairment like agitation, confusion, disorientation. That's a big red flag. And then you don't want to give with antacids. You want to make sure you're separating it by at least 1 hour, and just counsel patients on making sure they're taking in a lot of fiber and fluid to help with those side effects. So our friend Amelia Bedelia comes back into the office for her follow-up visit. Remember, she's our elementary school teacher with asthma and allergic rhinitis. She reports that her asthma control has improved. She's had fewer nighttime symptoms, so really only 1 to 2 over the past 4 weeks. So she's doing great. She's using her inhaler daily as prescribed, and we got her on the combination. Yay, insurance covered it. However, she mentions she's been experiencing frequent episodes of heartburn with an occasional sore throat and that sour taste in her mouth. So if any of you have ever experienced heartburn, you know what that's like. So current medications, we've got her on that Symbicort, so that budesonide and formoterol on that low dose, and she's also on that antihistamine 10 milligrams daily. Vital signs, look at that. Pulse ox has come back up to 98% on room air, and everything else looks good. So now additional history, she's telling you her symptoms of the reflux have been present for the last 2 weeks. She's never had similar symptoms in the past. She's not really having any red flags, so no dysphagia, weight loss, or vomiting blood. And then she's saying she has noticed that it's really getting triggered by certain foods, so spicy food, coffee, and she does tend to snack late at night as she's coming up with her lesson plans and getting ready for the next day. In your assessment, you take a listen again. So you're noting that she's alert and oriented, she's not in distress, still has a little bit of mild nasal congestion. Heart rate's good, no issues there. Lungs are now clear throughout. That's beautiful. That's what you want to see. And then you're also going to include your abdominal exam, and you notice that it's soft but slightly tender in that epigastric region. And that's where she describes the feeling of discomfort too when she's experiencing those symptoms. So what are our initial thoughts? And we'll go to our next poll, but how is she doing with her asthma management, and what else is going on with Amelia today? What are we thinking for our friend Amelia Bedelia? So first, how is she doing with her asthma management? Are we happy with it? This is her follow-up for asthma. Are we thinking we need to make any adjustments, or is she doing really well? How's that going for Amelia today? Asthma is better controlled. Yeah. Yeah, so I'm pretty happy with her symptoms and how she's describing her asthma. That's absolutely true. But what else is going on with Amelia today that would make me a little bit more concerned about her asthma management as maybe these symptoms are getting worse? What are we thinking about? What is she coming in complaining of today? Yeah, absolutely. She's been having some GI issues. And so recent onset heartburn, may still be having some regurgitation, aspiration, GERD, GI issues. Absolutely, you guys. So with GERD, I would be worried about her asthma getting more exacerbated, right? So there is a connection between GERD triggering asthma symptoms with that reflux, right? And so we really want to make sure we're treating the GERD so that we're also while we're keeping a close eye on her asthma symptoms, we're also treating the GERD so that it's not continuing to make her asthma worse. And so maybe that's something that was exacerbating it in the background at the last visit, but airways always first and foremost, and it's not really something that came up. But now that we've gotten her asthma regimen and her maintenance under better control, now she's noticing more of those reflux symptoms that maybe were triggering her asthma symptoms. So absolutely. So emphasizing the importance of managing both conditions, right? Because there is a correlation between the two. So I just want to remind you guys, and I see the time, so I won't go in depth, but the rules of two about how we can assess whether her asthma is controlled or not well controlled, and her treatment plan, we're going to continue with that Symbicort. So she might be having some irritation because of that inhaled corticosteroid. So we want to revisit making sure she's rinsing and gargling, but we're not going to take her off the Symbicort, right? Instead, we're going to add on a PPI like a Meprazole 20 milligrams once daily, and then have her come back and see how she's doing. And we're going to talk to her about those lifestyle modifications, like avoiding those trigger foods and avoiding eating late at night. Awesome job. So I know we have about 12 minutes left. We have a couple more sections to go through. I'm going to try to take us through at least one more section. I think we're going to run out of our antibiotic section, but I definitely want to leave some time for you guys to let me know how it went today, what you want to see more of, and what we can cut out so that we can make the most use out of our time together. So let me launch our next poll. And we'll go through this question together because it's a little bit lengthy. The most common psychiatric diagnosis are anxiety disorders, two most common, anxiety and depression. With that in mind, primary care providers are the first to recognize, diagnose, and initially treat. That is very true. You guys probably already know how hard it is to establish in psychotherapy. And so a lot of times in primary care, we are managing our patients' anxiety and depression. So what class of medications is the first line treatment? Is it A, B, C, or D? The poll is open. What do you guys think? What's going to be our first line treatment? Absolutely. SSRIs are our friends. So if you wanted the explanation, that's what our Q bank will give you. So let's quickly talk about SSRIs. So sertraline, fluoxetine, escitalopram. So these are indicated for both anxiety and depression. Also things like PTSD and OCD really widely used. How do SSRIs work? Remember, serotonin helps regulate things like mood, sleep, your whole GI system. And serotonin's mostly found in your gut. So SSRIs, they block the absorption of serotonin, making more available in the brain and in the rest of the body. What ends up happening as a side effect is a lot of GI side effects, right? So that GI tract contains a lot of serotonin receptors, and when you increase the availability in the body, you create like an overstimulation of these receptors, so you get a lot of GI symptoms. Biggest thing to monitor for is really that serotonin syndrome. Again, too much serotonin in the body. We really want to be mindful of that. And then increased risk of suicidality once patients kind of come out of that depression. That's more for depression. And once patients come out of that low mood, they might be more inclined to act on their suicidal ideation. So you really want to screen for that as you're caring for these patients. So here's our friend Dan. Dan Johnson, 32 years old. He's coming in with generalized anxiety disorder. He's diagnosed a year ago. He used to be in psychotherapy. He's not currently. Does have a family history for depression with mom. He's a registered nurse, currently an NP student. I had a little fun with this. I thought you guys could relate to it. He occasionally social drinks, but no recreational drugs, no smoking. Chief complaint, I feel anxious all the time and I can't focus at work or school, right? He's not currently being treated. He's on some medication for IBS and a multivitamin, but he's really not on anything quite yet. And his symptoms recently, he's been persistently worrying about work and deadlines, difficulty falling asleep and staying asleep, frequently waking at night, and then reports a lot of fatigue and irritability during the day. General exam is fine, maybe some mild tenderness in those upper shoulders. He's holding some tension in those shoulders and neck, but generally his exam is normal. So what are we thinking? Let's go to our next poll. What are our initial thoughts for John? Is he able to manage his stress and anxiety well right now? So is he doing well? What are we thinking for John? No, a lot of no. Yeah. Yeah, John's having some trouble right now, right? Absolutely. Yeah, he has generalized anxiety disorder. Yeah. 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 He needs to think of self-care. Absolutely. Yeah. So you guys not doing very well. So what are some things that are popping up? He's not doing very well at school. He's not able to concentrate. It's affecting his sleep quality. It's significantly impacting his daily function, right? So he's not managing his generalized anxiety disorder well. He's also showing maybe some somatic symptoms of anxiety with the muscle tension. So you do your due diligence, you do a GAD score on him and a PHQ-9 just to make sure when we're starting him on medication, we're assessing the full situation so that we can screen for suicidality and no suicidal or homicidal ideation. So that's good. And he's now open to exploring new therapy options while he's looking to reestablish with psychotherapy. So he's open to pharmacologic treatment. So what's your treatment plan for Dan? Let's go to our next poll. If it'll let me. What is our treatment plan for Dan? What are we thinking? What medication would you start him on? SSRI. Yes. Very nice, you guys. So which one? I like sertraline. I would start him on 25 milligrams daily. We plan to titrate it up to 50. I like to really start low and go slow to see how patients do on the side effects. Have them come back, gives another option to really check in. Patients open up a lot more on that second visit. And then I'd probably keep him there at 50 for a few weeks and reassess and see how he's doing with reestablishing with that psychotherapy. I really am a huge component of getting patients back into cognitive behavioral therapy along with their SSRI treatment. And then we're going to talk to him about a lot about his lifestyle. So talking about relaxation techniques, sleep hygiene, and you guys talked about the rest. So what else? We talk about exercise, nutrition, and what does his social support system look like? That's going to be big. So we really want to find out what kind of support does Dan have as he's going through a very stressful time with completing his master's or doctorate degree. So when we're prescribing these SSRIs, remember, we want to manage expectations. So we want to talk to patients about the gradual onset of SSRIs. Typically, it takes 4 to 6 weeks for patients to really see any full benefit. And they need to know that ideally, we need to stay on it. This is a commitment. We need to stay on these medications for at least 6 to 9 months to really help prevent relapse, right? And we can't stop these medications abruptly as we're titrating up. We also need to be titrating down when we're coming off these medications. He's a social drinker, so I really want him to avoid alcohol while on these medications, and then really talking to him about the importance of routine follow-up. I want to see how he's doing, have him come back in. And then safety plan. I don't know if you guys have learned about this in school, but it's something that really stuck in my brain when I was in school, and I like to really talk to patients about this, is that what are we doing if we start to have some suicidal ideation? What is our safety plan? Let's come up with that together so you know your resources and where to reach out so we keep you safe, right? And that could include a hotline or a family member who's aware of what's going on, and we have those open conversations to keep our patients safe. So really discussing and documenting a safety plan with your patients is going to be really important. All right, you guys, I think unfortunately we're going to have to stop there. We didn't have time for our antibiotic section. We've got about 4 minutes left. I'm so tempted to keep going, but I think I'm going to have to stop. Let me see how many slides there were. Let's do this practice question together because I really want you guys to get this practice question too. Okay, so it's kind of wordy. I'm going to let you read it yourself together. And what do we think is the treatment plan? I'll summarize it for you guys. So a 9-year-old comes in, sore throat, painful swallowing. He's got a low-grade fever, no other upper respiratory symptoms. You look in his throat and this is how it describes it. So it doesn't tell you what he has, but it describes it. He's got that palatal petechiae, that tonsillar hypertrophy with exudate, erythematous oral pharynx, and then those lymphadenopathies of that anterior cervical chain. You've ordered, it just says rapid antigen detection test that confirms your suspected diagnosis. So guys, what are we thinking? What is the suspected diagnosis? Oh, it's not an open text. So we're thinking strep, right? So which is the best primary care treatment for strep? Is it A, B, C, or D? Let's see what you guys said. The poll is up. And you guys all said A, beautiful. Penicillin is going to be our first line. And you can look at the explanation more detailed if you want. So we have our penicillins. Those are really good for ear, nose, throat infections. You want to watch for, it's a very common cause of drug allergy, so you really want to watch for that. Patients allergic to penicillins, there's a potential cross-reactivity with cephalosporins, so keep that in mind. But penicillin is bactericidal, so remember it kills the bacteria rather than inhibiting its growth. So if you don't remember those terms, go back and review narrow versus broad spectrum, bacteriostatic versus bactericidal. And then we have our cephalosporins with all the different generations. Those are also bactericidal, and those are really good with the upper respiratory infections, ear, nose, throat, skin, urinary tract, bone infections, monitor for C. diff, and then again, with that penicillin allergy, there's the known cross-reactivity. And then you have your macrolides, and those are really good, again, for your GU infections, skin infections, respiratory, and these are more generally bacteriostatic, and you want to make sure that you're administering with meals to help reduce some of those GI side effects, and that prolonged QT is a big one. Also, a lot of drug-to-drug interactions with this medication. Fluoroquinolone's biggest thing is that black box warning for the tendinitis or the tendon rupture and QT prolongation. So when I think of fluoroquinolones, you really want to be thinking tendon rupture, QT prolongation. And these are also bactericidal. We use them in STIs, UTIs, skin infections, all of that. We don't have time for our case study, but hopefully next time. I do want to make sure we do our wrap up with our quick Slido at the end here, because I want to hear your feedback. If you have to hop off, that's okay. I know we're really just 1 minute left in our presentation today. Those 2 hours go by fast, right? So just to wrap up, remember, focus on drug classes. You're not going to know everything, and that's okay. But if you focus on drug classes and break it down by body system the way we did today, that's going to be really helpful. And then really focus on the pharmacology that's going to help you understand those side effects and those contraindications. And if you have any questions, you can reach out to us. Again, if you're not already following us on our social, please do. We have a lot of free content for you. It's all student driven, so feedback is really important to us. And I like to make sure that I leave room for feedback today. Everyone seemed to like Slido, which is great. And this is just an open text. Tell me what topics you'd like to see more of. And as you guys are typing that in the polls, I wanted to make sure you guys knew. Again, we pulled a lot of questions from our question bank today. We also talked about those on-demand videos going more in depth about certain topics that you need to go more in depth on. We have live reviews, so those are 3 days. They're all inclusive, meaning that we cover A to Z for what you need to know for your boards exam. So for those of you getting ready for boards, you want something full coverage. We talk about everything, and it's full day Fridays, half day Saturday, half day Sunday, and it's live. So you get access to myself and the other instructors. And if you needed mentoring, the SurePass Pro is a great way to bundle it all together because you get some mentoring in there too. But the SurePass and the SurePass Pro have a pass guarantee. So that's a really nice deal. But thank you so much for joining me today. I love to see the feedback. So more farm seems to be the biggest one, and that's what we have heard from you guys in the past, and that's why we put together this series, and that's why we've been focusing on pharmacology in these free weekly webinars. So again, if you're not already part of our social network, really get on our social network. Sam does a really good job of posting these lectures onto our Facebook group. So it's just FNP Pass when you go on Facebook, and all these lectures are available to you, including all the lectures we've done this past year. And starting in December, we really kicked it up with pharmacology because that's what you guys were asking for. And this is a really student-driven product, meaning that we want to hear your feedback, tell us what you need more of, and we will create that content for you. Archer is really big on providing high quality, effective, and affordable content to our nursing community to help support you, not only in your training, but once you get into clinical practice. So please don't hesitate to reach out to us for anything that you need, including mentoring or any kind of building your support system as you're going through this journey. I'm seeing a lot of antibiotic uses. Yes, we ran out of time, and I apologize for that. This was the first time I put this webinar together. And so let me know if there are things that you felt like, we didn't need as much of that, but I was trying to really pick all those high yielding drugs, and everything seems important when you're putting it together. So, labor of love. But yeah, we do move pharm class to 2.5 hours. I agree. I'm like, maybe I should just do a 3 hour pharm class. Yeah, I agree. Did you guys like the case studies? Did you find that to be helpful? You can put that in this word cloud if you're still with me. But I was trying to do the case studies, and that took a lot of time too. But I think it is a good way for um, students to really learn the information. And I see a lot of love case studies, so that's great. Yeah, and the case studies take a long time to go through it, but I think it helps you guys take the information and use it critically, so it's really helpful. Guidelines. So we definitely do more of like dry guideline presentations during that 3-day live review when we're really getting you prepped for your boards. And we've actually noticed a lot of students are using our 3-day live review for prep, getting into clinical practice too, because we really cover everything, including guidelines. And so I didn't focus on that in the pharmacology. We talked about GINA guidelines a little bit as we were going through the respiratory, but it's a lot to cover in one course, so we break it up. But if you wanted to see our presentation on guidelines, I'm not sure if we've done one with these free webinars in the past, but definitely in our 3-day live review, we have a whole section on guidelines. So absolutely. But that's great. STEM. When you guys say STEM, I'm not really sure what that means because I think my kids, science, technology, education, math. So elaborate a little bit more on that for me. But, well, great. And then brain. So yes, we're doing Brittany did a neurological presentation or webinar just this past Monday. So I see brain in there. So Brittany did a neuro presentation on Monday. We have actually a lot of neuro coming out for you guys in the next month in February because we're practicing some things and working some things out. So definitely you'll see a lot more neuro in February. So that's good to see. And I'm glad it was helpful. All right, you guys, we're about 4 minutes past the hour. Really, 2 hours goes by so fast. Thank you so much for joining me today. I really had a lot of fun with you. I really appreciate everyone's participation and attention. And I will definitely be doing this 2-hour pharmacology review again with the little tweaks to help us get those antibiotics, that antibiotic case study in there as well. So have a wonderful day. Good luck to you all, and please reach out if you need us.